Welcome everybody. This is the first UK Healthcare Tableau user group for 2026. So I think we're allowed to say Happy New Year. I'm your host for today, Steve Adams, but I've obviously a lot of work and effort that goes behind the scenes with everybody. We take it in turns. There's Charlotte, Rowan and Sarah who help out and host individual events during the year. Bit of admin at the background, just in case you haven't come along to one of these meetings before. It's well worth realizing that there are multiple in-person Tableau user groups you can also attend geographically. Here are some of the ones we think you might have access to in London, Nottingham, Scotland, UK, Northeast, Northwest, and Tableau data. If you go onto the Tableau user groups website, which is just Tableau user groups, you will be able to sign up for those and hear more about their events. There's also some online virtual groups which are very, very handy. We've got the AI and Tableau user group, the analytics Tableau user group. So that's more intermediate stuff typically, but we've also got the Tableau News, the Newbies user group, which has multiple people presenting for people who are fairly new to Tableau, so you're going to get lots of learning going on there. And there's also specifically an accessibility Tableau user group as well. There are multiple other ones, of course, so do have a look around the Tableau user group website because there's some fantastic stuff going on. And likewise, do recommend, if you're not already, going to the Slack community, which is free to join. There are multiple Slack channels in there. Again, ask people questions and get help and find what's going on in the Tableau community as well. And for example, I plucked this one out. You can watch recorded content from DataFam Europe, which took place just December, the end of last year. You take that QR code, you can watch that on demand and for free, as well as catch up on some of the Tableau keynote information from Dreamforce as well, from anywhere you are. And within the community, for example, you can request a Tableau mentor. So you can go into the Slack, request mentorship workflow, and if you want some help, that's a fantastic way to get it. It's coaching, leadership, etc., etc. So some great free resources for you, apart from what you're going to be seeing today. At our next event, we have Miles Henderson presenting, which is going to be on the 26th of February at 1 o'clock. Soon after this event, you'll be receiving emails. So you've signed up for this event, so that means you should have signed up automatically for membership to the Tableau user group, healthcare group. So you receive that. If not, go back in and sign up. But today, I'm going to hand over to the team, which is including Miles as well, but also Anthony and Hamza from Zebra Healthcare. So I'm going to stop sharing my screen and hand over to you guys.
Thanks, Steve.
There you go.
Great, thanks. Great, thanks a lot, Steve, and thanks for the opportunity for us to present today. And if you can just move to the next slide, please. Great, so just a couple of bits of housekeeping, I guess, before we get into the main presentation. So the three of us have decided not to do any kind of personal intros because our bios were kind of already included on the invite, and we've also put some QR codes to our LinkedIn profiles at the end of the presentation. So feel free to kind of connect with us via that route after the presentation. And just one other thing to mention, there is some slight sensitivity around some of the data that is being presented. So NHS England have asked if it's possible not for us to take any screenshots and share them outside the meeting. Great. So the plan for like the next 45 minutes to an hour is really for us to kind of present our journey as Zebra Healthcare, supporting the national COVID vaccination program. And that from at the start was moving from a position of having too much kind of unstructured data, moving through to having interactive dashboards, initially supporting the COVID vaccination program, which was the main part that Zebra Healthcare was involved in. And then we'll be handing over to the kind of headline act for today, which will be Miles, who'll be kind of showing you guys some of the latest Tableau dashboards that he's been working on as part of the vaccination and screening program. Feel free to, as Steve has mentioned previously, feel free to kind of put any questions or comments that you've got as we go through the presentation, and we'll try and pick those up as we go through. And if not, we've also got some time for discussion at the end of the presentation. Can you go to that? Yeah, thanks, mate. So I think one of the things that Hamza and I are always a bit conscious of as we sort of become older and kind of more experienced is that we have the risk of kind of being those two old guys that are sitting at the back of the room still talking about the war. But unfortunately, we are going to have to take you guys back a few years to when there was a war, but it was a war against COVID. And so the reason we kind of put this slide up primarily is not because of the politicians that are on there, but actually what we thought was the most important part of the COVID vaccination program, which is to the very far left of the slide, is the data. And the kind of, as part of the COVID vaccination program, it gave the NHS a massive opportunity and a really unique opportunity to use all the massive amounts of data that it was collecting as part of the vaccination program, and really having a chance to use that in a really smart and more proactive way, which could have a real positive impact on the health of the nation. Can we go to the next slide, please, Hamza? And so the National Performance Team, as part of the COVID vaccination program, which was set up in 2020, and governments all over the world and our government as well, did what everybody else would do and just kind of threw money at the problem. And so initially, and prior to Zebra Healthcare being involved, the performance team was supported by a large consulting team, and their kind of main way of sharing data with the regional teams was through a process of developing a PowerPoint presentation, which was shared every Monday, which was called the Monday Pack. And the process for that was that at 9 o'clock on a Monday, the team would receive a massive Excel file, which contained summary data of all of the vaccinations that had taken place in the previous week. And that data would be cut in various different ways. So the different manufacturers of the vaccines, the intervals between first and second dose. There was lots of data around the vaccination levels with the different ethnicities across the country, the deprivation levels, how those vaccines were being delivered to different deprivation levels across the country. So lots and lots of data to kind of to look at, and basically the consulting team there created a PowerPoint presentation from that Excel data. So it was static data that was developed across the whole day. It took a whole day to develop this pack, and it would then be sent to the regional teams. And the regional teams basically would look at that data and try and kind of change their strategies and course correct based on the data that were delivered to them for the previous week. So it was quite a kind of slow and cumbersome process, because you're always looking at data that was reflecting back to the previous week. Now, I guess as with any NHS projects, budgets started getting tight, and what then happened with the program is that the expensive consulting teams were phased out, and the performance team started bringing in smaller and cheaper independent consultants, and that's where Hamza and I joined the team in 2020. And what we did was we just picked up where the larger consultant team had left off. So we continued to turn the handle on taking the data on a Monday morning, creating this Monday pack and getting it sent out. And we're very proud to say that it was always sent out on a Monday. That might be like 10 p.m. on a Monday, but it was always sent out on a Monday. But as time went on, that team, and at this point, Hamza and I created Zebra Healthcare because we could see that there was an opportunity to look at this data, to analyze this data, to share visualizations in a more meaningful way. So the team that was creating the Monday pack grew, and as it says on the slide there, it went from just sort of me and Hamza doing it to a much larger team. And actually, it started then not being delivered on a Monday because there was so much information that was being crammed into the PowerPoint. So it started going out on a Tuesday morning, then Tuesday lunchtime, then Tuesday afternoon. So actually, by the time it's the inboxes of the senior people in the regions, and by the time they've kind of disseminated that to their operational teams, they're probably looking at information that is at best 48 hours out of date and static information. So we saw that there was a better way to kind of have this information delivered to the teams in a more meaningful way and a way for them to have more actionable insights. So it's probably not a spoiler alert to say that we didn't choose Power BI. We actually looked at Tableau, and I'm going to now pass over to Hamza, who's going to talk you through why we chose Tableau for this team, and then show you what we then did with the data afterwards.
Thanks, Anthony. Good afternoon, everybody. Hamza Jamil, as Anthony mentioned, we're not going to do sort of deep dive introductions, just get right into it. I'm going to just make another bit of housekeeping. I've never used this Bevy solution before, and so I'm sharing my screen, so I can't see anybody's faces, I can't see hands, I can't see any commentary. So Steve, Anthony, anybody, if anybody wants to sort of jump in, ask a question, please just interrupt me, free flow, because I can't actually see anything that's happening other than what's on my screen that you're seeing as well. So with that out of the way, let's talk a bit about the kind of next iteration from what we've just kind of spoken about in terms of that PowerPoint deck. And that PowerPoint deck, I was going to sort of build it up a bit more. That Monday pack was just one of the kind of key documents that needed to go out every Monday, then Tuesday, and actually at one point I think it started even going out on Wednesday. But that was one of the core data sets that the team was producing. There were other data sets that were being produced as well in isolation. And that's an important point that I want to come into. But just starting on that Monday pack, you can imagine you've now got something north of 150 slides that you're disseminating to regional directors of commissioning, who are then kind of cascading it down. And that information is cut at a national level, it's cut at a national regional level, it's cut at a regional level, and then it was actually cut at an ICB level. So you've got insane amounts of information. And the problem we were having with it is we were looking at it and going, what's the RDC even going to do with 150 pages, right? Do they actually have the time to scroll through all of this? Or are they going to go, hey, what do you want me to do with it? Right? So that was one of the things we were thinking about. And we were thinking from our perspective as well, if someone landed this in our mailbox, would we look at it or would we go, is there an action in here? If there's no action in here, it goes into the delete box, right? But so why let's go back to why Tableau. So when we started thinking about this, we knew how the information was coming out. Everything was sort of consolidated mainly into Palantir, aka Foundry, for those of you in the NHS. And then we had SQL queries, we had egressions that were being written where you're, 10,000 rows, I think was the max, stuff coming into Excel. We've already talked about stuff going into PowerPoint. So you've got this kind of mixture of information, and then somehow it all goes back into a PowerPoint deck, or in some cases, even a sort of standalone Power BI application to show some data. But the minute that data leaves Palantir Foundry, it's out of date. And we can talk about, all the problems we were having with that as well, because by the time you send information out, that's now sort of circa 48 hours after the event, and it's also looking at the week before events. If you're suddenly looking like you're low on uptake, someone's going to shout, right? You're making me look bad. I'm not actually that bad. So that real-time data was becoming more and more of an issue for us. So we went to the data team and said, hey, folks, why are we doing it this way, right? Why are we pulling data out only to kind of shape it and put it back in? And without trying to sound negative towards the Foundry or Palantir system, it wasn't actually built for visualization as such. It's an analytical tool. So yeah, you can write queries and build out contours and all that kind of fun stuff. But if any of you have ever written a contour, not that I have, but we work with contours. The fact is that you've got millions and millions of rows of data needing to be compiled. And so when that contour would run, you could be waiting a very, very, very long time for the actual data to get presented. And God forbid you get one little thing wrong, you start the whole thing again, right? So it was an absolute nightmare to use in that sense. So like I said, we went back to the data team and said, hey, What can we do about this? And interestingly, just for those who were on the last Tableau user group last year, there was kind of talk about is Foundry connected to Tableau? And I think me and Miles were on that call. We were talking about actually, yeah, Tableau was connected to Foundry as the sort of, the first ever connector outside of the sort of Palantir ecosystem that NHS England had built that allowed that data to kind of flow directly into Tableau. So that was already a big tick in the box for us, right? We're like, wow, great. We've got visualizations through Tableau. It's, best in class. It's always been the kind of, the Rolls Royce from that perspective. But what was even more important to us is that, again, for those who you may have remember Foundry from back then, and it still works the same way, everybody had a purpose assigned to them. And that purpose would say whether you have national level access, regional access, ICB access, PCN access, et cetera, what we had built already was the Tableau server overnight was pinging Palantir, picking up the purposes assigned to those users and reflecting them into Tableau. So we had a ready-made solution. From our perspective, we were like, wow, we are winning from the get-go, right? The team had already produced a style guide for Tableau that the NHS England, and so we were looking at, right, we've got the product, we know the product, we talked about it being best in class, and we also know that Tableau is really, really good at handling lots and lots of data without doing that kind of necessarily rebuilding of the data each time. So we were super happy with what we needed to do. So we set on a journey to start building out. Now, as I go through this deck, and like Anthony mentioned, Miles is the real headline act because he's going to show you where it's got to. But what we want to just kind of show you is how that journey started and how it's evolved. And so what we're going to do is literally go into the vaccine program and start with the Monday pack and how it iterated from there. Again, just a bit of housekeeping from the get-go. We were never allowed to use red, amber, green kind of colors because that just was it sounded like we were being competitive. And we never wanted any region or ICB, et cetera, to sound like we were being in a world where they were competing against each other. Data you're looking at here is completely fictitious, but just to showcase what we wanted to do. Now, like I said, just for the purposes of today, we're just going to talk about a few dashboards. But the ability that we had with Tableau was to consolidate lots of data, not just through Palantir, but also through systems like Atlas. For those familiar, I think it's called Atlas, where you've got geospatial kind of activities that you could look at as well. We were able to bring all of that into one single platform. So now we were being able to look at data, not just from one perspective. We had multiple data sources, so we could make some real intelligent kind of discoveries, and more importantly, take action against them. So let's look at this straight away. Here we've got the kind of the Monday Pack's first ever page in the sense, and what this is basically showing was at this moment we've got our uptake, we've got vaccine. I won't go through all the headers, but just to kind of point you in the direction. I don't know if my pointer works over here. We were now taking data directly from all our data sources twice a day, 7 a.m. and 6 p.m. And both those timings are very, very important. And the reason being is because at 8:15 every morning, the SRO at the time, Emily Lawson, had her SLT. That SLT was all the RDCs, the regional directors of commissioning, all the other senior stakeholders. It was massive. Probably north of 150 people would be on this call every morning at 8:15, and on a Friday in particular, the Minister for Vaccines, Nadeem Zahawi, would be on, for example, on a Friday as well. So we had to be really, really sharp with what we were showing. Now, again, if you remember, again, Anthony kind of mentioned the war against the vaccine. This vaccine was beating us up left, right, and center, right? When we thought we were ahead of it, it would pivot and do something different, and boom, we've got another variant. We thought we knew what it was doing, and boom, it would do something different, right? So each morning, the ability to kind of see a visual about what's happening across the nation was very important, because we could go, right, we're now looking at live data. This data was cut at 7 a.m., and then the next meeting was at 6 p.m. And the objective here was to go, what can we do today in flight? What incentives can we do? Because obviously we can't force citizens into a pharmacy or into their GP practice to get a jab in the arm. What can we do that would make a change. And that's why we had a 7 a.m. and a 6 p.m. because again, at 6:15 p.m. every day, the SLT would meet again as a smaller group to go, what did we achieve through that day? So real-time information that we could actually count and see if we're making differences. And interestingly, as you can imagine, when you've got large numbers and large amounts of activity happening, those percentages are changing. And the ability here to go, we've done something this morning and we see an uptick. It could be coincidence, or it could be because of that thing we've done. Let's see how it plays out the next day. Gave the program an ability to make decisions and continue doing things with seeing real results. And we had some obviously supersonic people on these teams who were used to working in the NHS, working on various programs, who would say things like, right, we've done this today. We might not see the outcome till Friday. We might not see the outcome till next week, but we're going to keep a track of it. So within the system, we've got those flags saying, these are the kind of incentives we put out there. Let's see how it plays out. I'll take a pause there if any questions. Like I said, I can't see any hands or screens, but if not, I will jump to the next screen.
No questions at the moment, Hamza. Just a few people agreeing with what you've been saying.
Perfect. Let's go to the next screen. So on that previous screen, we had London, and London as a region always used to be in the lower uptake cohort, high levels of deprivation, young age groups, etc., etc., etc. The amount of phone calls we would get from powerful people in London to say it's not fair, change the data, well, not change the data. Can you show the data in a way that's being more representative to London? We're like, well, it is being representative to London. It is what it is, right? But what we wanted to do is then create a dashboard. And again, apologies that the numbers aren't all there. Like I said, it's fictitious. What we wanted to do is go, well, how can we look at London at an ICB level, break it down by ICB level, and go, what does your nearest ICB look like? And so we created the peer group comparison idea, right? So, if you look at the big cities, you got London, you got Manchester, you got Birmingham. Within those cities, they're going to have ICBs that are going to be similar. And so what we wanted to do is go, well, right, London, let's not single you out. Let's look at it at an ICB level and see what we can showcase now. And that way, you're not alone, right? We know we have a problem, but let's try to target this problem together, right? Now, we can't boil the ocean. We can't, overnight solve high levels of depravity, but we can look at what we can do to encourage people to do so. And at the time, we had all these statistics, and of course, NHS is always gathering statistics about, people, for some reason, the higher levels of education you had, the more chances are that you would get vaccinated. The lower education levels you had, the less trust you had in the NHS and what the politicians were saying. Whatever their political background is, it wasn't making a difference. This is what our data was showing us. And we were thinking, well, how do we target that noise? Because again, if you remember back in those days, suddenly everyone became a pharmacist, right? Everyone was talking about, oh, have you got Pfizer? Are you taking Moderna? It's like, why do you care? Has anyone ever asked that question before? But people were asking these questions, right? So we wanted to take a deeper look at that data and started looking at it from an ethnical side profiling as well, to go, well, if certain areas have a high level of ethnic groups, how can we influence that? And two very interesting things came about this, right? One, which was really supersonically bizarre, right, was at one point we had noticed that China had done a very, very high media push in China that had a vaccine uptake. And we saw in England, the Chinese population, the Chinese ethnic group, also have an uptick. And we're like all scratching our heads going, what's going on here? And it was again, just speaking to the broader NHS and people who are actually in the kind of areas talking about, well, actually, some people will be watching TV that's broadcast from China. Some people in Pakistan will be watching TV that's broadcast from Pakistan, and such like. So the influence is not just local or national, it's also international. So again, as Anthony mentioned, all the governments were talking together. It was like, whoa, this is kind of interesting. How do we use this to help people get vaccinated and help themselves and help others around them? So that was one really interesting thing we found. The second really interesting thing we found was there were three particular ethnic groups. And forgive me, I don't recall the three, but I remember there were three, which had a low uptake. But as we were looking at the data from a very single platform or single view, we weren't able to actually see, we never actually had an ethnicity issue in those three groups. We had an age profile issue. And so what we were actually finding is that the 18 to 25-year-olds, had a very different outlook to being vaccinated, and their, what should I say, ability or confidence in their well-being and their health. They had a lower uptake. So it didn't matter whether you were British white or you were British Pakistani or whatever you were. It was an age thing that we were looking at, not an ethnicity thing. So again, just by being able to triangulate different data sets allowed us to look at the data differently and take a different action rather than kind of going, right, we just repeat, rinse and repeat, rinse and repeat, rinse and repeat. The whole cohort, the whole system was able to think differently. And this was very important because NHS England, the team that was pulled together for the COVID program was pulled together from people across the NHS who are now able to take that information further back when they, back into their regions to go, hang on, when we look at data from different angles, we're actually able to take different actions and actually learn from it. So again, just some really cool intelligence that we were able to get. And then moving on, as the program was building out, obviously things started changing, right? What we're now looking at is not whether you've taken your full dosage, which was first dose, second dose, then we had the booster, then depending on your age profile, we had the fourth booster or the fifth booster, et cetera, et cetera. So we started noticing that our friends at UXA were talking about, actually, we need to look at dosage as a pattern, and that we need to almost like reboost everybody at certain profiles every 6 months. And that may be the immunosuppressed, the over 65s, and such like. And we'll come back to the immunosuppressed later as well, because it's a very important cohort, the most at-risk citizens in the world, I suppose, and how we needed to make sure that they were being vaccinated. And so what we wanted to do here, again, this wasn't to call anybody out. This wasn't to kind of go, you're not doing a good job. This was to kind of go, well, look, this is where we are right now, right? If you look at the kind of left top graph, this is what the behaviors we're expecting, because obviously between month 6 and 12, you're not really going to get vaccinated because you've been vaccinated. But we want everybody to be, on that situation where they've got a dose every 6 months, and everything was kind of, positioned to say, it would be great if everybody exactly, 6 months and 1 day later showed up at their GP or at a vaccination center and got a jab. But we knew that wasn't necessarily going to happen. But we wanted to kind of show what it was looking like, so that the regions could now work with their PCN network to go, right, folks, this is where we are, this is where we stand, what can we do about it? So this whole kind of section I've been talking about getting people vaccinated, we kind of looked at it as the incentive side, right? How can we incentivize citizens to basically be safe, get vaccinated, do what they needed to do? Because again, you think about the program when it started, everybody raced to get vaccinated. We had the opposite problem. We didn't have enough doses, we didn't have enough places. And then as the kind of, the nature of the disease was changing and it wasn't as fatal, people's responses were changing, et cetera, et cetera. But we still wanted to keep people, vaccinated and do the best we could. So this is the side we want to talk about on incentive. I've got a few more slides, just making sure I've got enough time for Miles to talk about what we would call control. But again, I'll just pause for breath there and see if Steve, any questions or thoughts people want to reflect on before I move on.
No, we're all good, Hamza.
Amazing. All right, great. So I'll try to speed through the next ones here. So as I mentioned, right, one thing was, let's get people vaccinated. Another thing was, we can only get people vaccinated if we've got vaccine. And one of the things we were always kind of looking at or ending was, where's the vaccine and how much of it's being, bizarrely enough, wasted. Now, I'm not a clinician, so I'm going to say things, and please, if anyone's a clinician on this call, don't shout at me. But the modeling team had done this piece of work with the manufacturers that there will always be an element of wastage. When you click open the vial, there'll be a bit that might spill out. When you, I think, pull the shot and you squeeze a bit out, so if a vial's supposed to have 6, sometimes you might get 5, sometimes a vial's a bit fuller, you might actually get the amount you need, et cetera, et cetera. But the target was always to kind of go, right, let's try to model ourselves on a 20% wastage. And the reason why there was a 20% wastage allowance was, again, what we didn't want to happen was that if there were 3 people waiting in the waiting room for a jab and they had to crack open a new vial, we didn't want the clinician, the nurse, the healthcare provider to go, oops, I don't want to crack open this vial because 2 doses are going to go to waste. The idea was let's try to be as sensible and kind of manage the vaccine as best we can without kind of telling somebody sitting in the waiting room, thanks for waiting here for an hour. Can you come back tomorrow morning because I'm not going to crack open this vial, right? So we're trying to be sensible about that. But we were looking at again about thinking about wastage and where we were seeing, for example, in the bottom right corner, where you've got low VVs, low vaccine events, and high wastage. What's going on over there? And apologies, these are screenshots, so I can't actually show you, but and I should have mentioned actually on the previous screens as well. All of the things you're seeing are drillable, right? So in terms of that scatter plot diagram, you could click onto it and it would go deeper. But then you can see straight away, like in the top middle, we had a higher level of wastage on Moderna. And if I click on that, I just wanted to highlight Moderna. High level of wastage, 23% wastage. And again, if you remember what I was saying earlier, we had people in society who suddenly became pharmacists, right? They were kind of thinking about, well, I don't want Moderna, I want Pfizer. It's been around longer, et cetera, et cetera. And so if I look at, for example, now Pfizer, 10% wastage. And you can also look at, let me just go back actually 1 second. If you look at the scatter plot and how it's behaving versus Pfizer, far more stable. People are now more used to that vaccine. The model wastage on Pfizer is 10% versus 23% on Moderna. And all of this is really important for the clever people in supply chain to kind of think about, well, what do we need to do? Who do we need to work with? Who do we need to work with at the local levels as well to kind of go, people, it's all the same, right? The vaccine's a vaccine. Please don't think about the model. You're never going to go into your pharmacist and go, is that paracetamol by X company or is it paracetamol by Y company? Why are we doing this now? How do we encourage the right kind of behaviors? But the reason I talk about this being a more of a control product is because the vaccine, to some extent, was under control, right? We could say, right, we're going to buy X of this product, we're going to buy Y of this product, towards the latter periods when the vaccine was more available. As I mentioned, though, we were able to drill down into the kind of more granular levels. And in this case, we're going to look at, and again, if anyone's from Leicester, ICS, this is all fake data. Please don't think we're singling anybody out. But we could now go straight into the ICB. And I'm just going to spend a few minutes here. I definitely want to make sure I pass the mic to Miles. Start looking at, well, we click into the ICB. Let's start looking at the profile of what's going on. And there's lots of information here. And a lot of this information was super valuable for the supply chain teams, but also for right sizing, right? And by that, I mean, we're always working together with the sites to go, right, if you look over here, you've got your highest operational wastage on Mondays, Tuesdays, and Sundays. Why? You could work with them locally and go, what's happening on Sunday, Monday, Tuesday, where we have higher wastage? Are we closing earlier on those days? Are we not open as early on those days? What are we doing that's forcing this kind of behavior to happen, where we've got in the middle of the week a kind of relatively flat week? And again, if you think about it from the perspective of towards the kind of latter ends of the program, when the restrictions were lifted to some extent and people were now going back to work, all these things were changing our dynamics and meant that we needed to also think about, well, how do we stock the system to make sure we're now reflecting people's behaviors and people now going to the office? So do we need to be open before 8 a.m.? So people, before they go to do their job, are able to get vaccinated? Do we need to be open after 5 p.m. longer? So people after, all that kind of fun stuff was happening in the background. And this information and these views help those teams to do that. Just a couple of more slides, I think, and then I'm going to pass the mic to Miles, folks. Then one other thing, or two other things, like I said, I wanted to talk about. This vaccine was, and at least at the time, the most expensive vaccine, drug, whatever you want to call it, that the NHS had ever purchased in terms of its volume. And for people who may not know this, AXA would sort of buy it. That's the UK Health Service Authority would buy it, sit in their massive fridges. From their fridges, it would go to a regional fridge. From a regional fridge, it would go to an ICB fridge, etc. But once it would go to a region and to the actual site, it could never flow backwards. So if we had a shortage of stock in London and Birmingham had excess stock, it could never come to London. It has to come from the center to the region. It can never go back. And for this reason, but it can travel within the area. And that traveling within the area was called mutual aid. And the reason I bring this up is, again, what we were able to do with Tableau is take away commercial barriers. We were able to get this down to the super drugs, the Boots. It didn't matter who you were. We were supplying the vaccine to you, right? It was coming from the center. And so on this particular diagram, you've got a red dot, which says they're low on vaccine. You've got a green X that says they've got vaccine. And the idea here was to kind of just very quickly say to those sites, if you need vaccine, you're able to see your nearest site that has vaccine, so you don't need to call it from the center. And these slides went into more detail to kind of look at what the planned activity was. So if that site had a load of bookings and they were going to consume that vaccine versus actually they didn't have any on the national booking system, lots of vaccines booked, they didn't have a walk-in center proviso, et cetera, that were going to sit on that vaccine, it was going to get close to expiring and then pour down the sink. Can we move it? And again, it's actionable, right? So this wasn't now the center saying, hey, ICB, PCN, make sure you move your vaccine. This was giving them local control and that ability to do this themselves, right? And having that view about how would a pharmacy in one area know the pharmacy, 200 meters down or half a mile down, know that the other one was either low or high without something like this. So again, really, really valuable information that was, again, getting the vaccine in the right place, right sizing it, giving us the control to make sure we weren't wasting anything, and getting that best value for now the citizens to get vaccinated, and also the best value from a taxpayer perspective. We weren't pouring a vaccine down the sink because it was going to go to expiry. And then just an early kind of view, and for those who are using Tableau today, we'll laugh at this, but this was our idea of AI, right? We wanted to, I guess, kind of think about, well, we know a lot of information. Someone sitting at a site level, their job is not to understand supply chain. Their view is, I need to get jabs in arms. I need to look after my citizens who are coming to see us. So here was us kind of going, well, from what we know, can we give a few high-level sort of crib notes or whatever that says, based on what we know, have you thought about this? Without trying to sound condescending, but just kind of high-level views of what we had. And again, think about, this is obviously 4 or 5 years old, and Tableau and its intelligence has moved on leaps and bounds, and the amount we could now do is absolutely insane. And then last but not least, and this is my segue into Miles's world, and actually credit where credit's due, this actual dashboard was actually built by Miles way back when. And it's looking at immunosuppressed. And this cohort for immunosuppressed is a super at-risk cohort, right? These are people who may have certain medical conditions that make them more likely to contract COVID and have the worst possible result as having it. These people may be living in care homes where you're closely in close proximity to other people who may have similar comorbidities to you and at risk, etc. So this was a really great view for us to look at where we are from a care home perspective, where we are from a population perspective of those citizens in those care homes, and making sure that everybody there we're going to get as close to 100%, first dose, second dose, booster at a very minimum, and keep up with their vaccine profile. So I said this is my last slide. This is my segue to where it's now gone and where Miles is going to take over. But I think what I wanted to showcase was where we started, being very from those PowerPoint decks to now moving into our Tableau world, where we've actually got multiple data sets coming through, where we're actually able to take actionable insight. And this was just a kind of a small dip in the water about what we were able to do through COVID. But we also were able to look at hospital uptake and hospital admissions and a whole bunch because of the data, the richness of the data. And I can talk about how important this data was and how amazing it was and what we've left behind. But I'll pause there and pass the mic to Miles. So thank you very much for everyone to listen to that, and I hope that was helpful. Steve, I'll pass it back.
Hi everybody. I'm just going to turn my video off again because it seems to be slowing down my performance, but I'm just going to share how we're using Tableau now. Bear with me one moment. Can you see my screen?
Yeah.
There should be a thing called a care home vaccination dashboard in front of you. So so pretty much after the more urgent part of the COVID vaccination campaign finished and our teams were disbanded, I joined the analytical applications team. And one of the first projects, data sets I was asked to look after was the care home vaccinations. So can I just ask that for proviso for no screenshots to be taken off this dashboard? It's because it's got real-time information in it. So effectively, prior to me taking on care home vaccination work, we had a contractor who was using information from a website called Capacity Tracker, which was maintained by the Department of Health and Social Care. Now, Capacity Tracker was a list of all care homes in the UK, and care homes would go onto the Capacity Tracker website, update the population and vaccine uptake for their care homes, and then the previous person would then take a download from these websites, and then send out a manual spreadsheet every Tuesday and Thursday to regions so they could see what the uptake was in their particular regions for care homes. The issue we had with this is that it was not real-time data. It was sometimes these people had like 2 to 3 weeks time limit to update their vaccination and population counts on Capacity Tracker. So it was never real time. So what I wanted to do, after my experiences of working with Hamza and the skills I built up in Tableau, I wanted to put something, I didn't want those skills to go to waste. So what we did was, first of all, I took the care home data back to the bare basics and thought, what can we get from NDP? It was we weren't using FDP then, we were using NDP. So the first thing we had a look at was CQC data. CQC data is published every month, and it gives you an up-to-date list of care homes, and it will tell you which is a specifically elder adult care home, or is this a general care home that looks after everybody. So we looked at uploading the latest CQC data to an NDP every month in order to have an accurate view of all the care homes. We then had an issue where we had about, I say, a third of the care. So the care home population in the UK, if you look at official sources like census returns, should be in the region of 370,000 to 380,000. The initial figures we had coming from NDP was about 100,000 short. So we had 100,000 residents who we were missing. So when I took on the dashboard, not only did I want to report on the basics, we wanted to report by region, by care home, what the population was, what the uptake was for COVID vaccinations, but also where were vaccinations taking place in care homes which were not being recorded. So where are people being vaccinated in care homes that weren't shown as a care home residents? So we had to sort of find out where these 100,000 people were missing. So we have got a good relationship now with a data engineer who is in charge of mapping care home residents based on the address entered on their doctor's record to the correct care home. So we devised a process for that. It's not perfect. It's never going to be perfect. It all depends on the accuracy of address entered onto the patient record at the doctor's surgery. So what I want to do with this Tableau dashboard was, 1, report an uptake, 2, highlight areas where we think there's a data discrepancy, 3, look at where these care home residents are being vaccinated. So there's probably one of the misconceptions I found when first taking on care home reporting is that everybody thought everybody was vaccinated via a care home visit. So a group of healthcare professionals would visit a care home, vaccinate everybody in the care home on one day and leave again. And then that would be registered as a care home visit. And then we could say, according to extended attribute data, this many people have been vaccinated as part of a care home visit. But the thing you need to remember of care homes is not everybody is immobile. People go into a care home or residential home and they still have a full life. They can still walk, they can still go to town, they can still go on holiday, they can still go to a local GP surgery, or they can still go to a local vaccination centre, or they still can go to a pharmacy to get vaccinated. So we found as well that we had people being vaccinated without waiting for somebody to come to the care home. They actually went out and actively got the vaccination themselves, and we recorded that as activity. So what basically the care home dashboard did was look at anybody who data discrepancies, trying to work out where people were, which care homes were missing people, to find out how many people being vaccinated as part of care home visits, to find the uptake rates, etc. And then as we did COVID, in NDP, we then found that we decided, well, flu is just as important as COVID, so should we start looking at flu? So the care home dashboard has now been running for 4 seasons now. The first season was done as part of NDP, and then NDP was retired, and we were then upgraded to FDP. So we've been using FDP for care home data since the autumn of 24. So the care home dashboard has evolved very much over that time. So, and if you can all see now, you've got a Tableau dashboard in front of you. So I'm just going to go through some of the things we have. So I didn't just want it to be a dashboard that reports on uptake. I didn't want it to just be a generic list of figures. I wanted to be able to show you where areas were low on uptake, where areas were low on care home visits, where areas were low on etc. Care home visits, where which care homes hadn't vaccinated enough of their residents, to actually pinpoint where we could go to these care homes, and regions could go to these care homes and say, we need to get another visit arranged to do a mop-up on the care home residents that have been vaccinated yet. Or you've had some new care home residents join who haven't been vaccinated. Can we either arrange for them to go to external site to be vaccinated, or for somebody to come into the care home and vaccinate them themselves? So one of the things we have was a map. Now, the Green Book guidance from the JCVI is different. So for COVID, for COVID vaccinations in care homes, the JCVI recommend that we only vaccinate residents of a care home that is classed as an older adult care home on CQC data. Whereas for flu, JCVI recommend that all residents of care homes should be vaccinated for flu. Or, for example, so it was vice versa. So we had in a situation where the metric for measuring COVID uptake was different to the metric for understanding flu uptake. So what I did was put together this map. Now, you'll see it's different shades of red, and you'll see green areas. The green area is when we think it goes over 75% for uptake. So, for example, if we wanted to say, so if we know an area has gone green, we know it's doing well. So what I want to do is show you some of the work we've done on that. Bear with me, the map has decided to refresh itself. Can everybody still see it?
Yeah.
Cool. So the first one we have 4 different boundary selections. We've got region, and this should change in a moment. And then we have ICB, local authority district, and then electoral district. And then, as you can see, for each area of the UK, you have an overall percentage figure for each region, etc., which updates as the figure is done. So the first we're going to look at is uptake for autumn 25 for COVID. And you can see that we've got some areas in green and an overall percentage. So this further down the campaign, the overall percentage for the UK for COVID is 60.42%, and that's for older care homes. But then say we wanted to look at care home visits, we go to the metric and select care home visits. And this will change the percentages now, and you'll see the map should go quite green. So now we can tell that the majority of care homes have been visited. And if you hover over the actual area, we can tell for West Dorset, 87.5% of care homes have been visited. And if you look at the list, it will tell you the care homes where care home visits are not as high as they should be. Now, if you want to look at activity, so this is care homes where residents have either been vaccinated as part of a visit or vaccinated elsewhere. We look at activity, you will see that it goes very green. And as you would tell, all of the little percentage markers change based on the metric you select. So the South Devon, for example, is doing very well for activity. You've got 96.55% in Central Devon, 100% in Torridge and Tavistock. It's very high numbers for activity. So we know that we're doing very well in that respect. If you wanted to say select this red area here, which is Taunton and Rennerton, you are 72.34%. So they've still got a few care homes there which need to see some work. Now, as I was saying earlier, flu is a completely different metric. So if we go back to activity to uptake, I think what we find as well is there's a lot of, I think people don't tend to seek out the COVID vaccination as much as they used to. I think there's a bit of negativity regarding this. So if we want to then change that to flu, and then a total population, because that's what we're looking at. We want a total population of care homes to be vaccinated for flu. And now we have, you can see that the uptake for flu is much better, overall 70.92%. The Southwest is at 76%, and we're doing very well for flu. And as I say, you can pinpoint on each in particular area, and it will give you the uptake in that area. So we know, for example, that we're looking at uptake for autumn 2025 for flu. We're looking at electoral boundaries. Then we're looking at area name, Taunton and Minehead. Now, if you want to look at region, you just select region. And it would change this back, and then you'll see that it's now changed the boundary type to region. So by hovering over them, we can see where the uptake is. You can also look, so one of the metrics we like to look at is who's had vaccinations for both. So who's had both COVID and flu. So we call that dual vaccination. And we select that. And we can tell that the overall vaccination rate for the entire country is 57%. So we know that 57% of care home residents in England have had COVID and flu vaccinations. Then we have another metric called co-administration. So that's when a care home resident has received COVID and flu vaccinations on the same day. So you can see fully England, we're at 40.50% for that. So that's how we can tell if a care home, how uptake rates for visits, for flu, for co-administration, for COVID, for dual registration. That's how we know how we're doing in the country. Now, one of the problems we have with care home populations, people may understand, is that sometimes if somebody is convalescing in hospital, and aren't able to go home yet. They'll stay temporarily in a care home and then return home. But then you might have a lot of residents who sadly passed away. So it's very difficult to have a correct care home figure at any one time. So one of the things we have at the very bottom is a number of graphs that tells us where these people are. For example, we can tell for COVID only that 359 people have been vaccinated in a care home this season who have sadly passed away. We can tell that 33,000 people have been vaccinated in a care home this year, but they are not showing as a care home resident on their patient record. This could either be due to a care home not being correctly mapped to the actual care home UPRN code, or the surgery hasn't updated the care home resident's address. You also have the thing where you got 25,000 care home residents who've actually moved away, so they're no longer registered for GP practice. They've moved out of the country. Now, by hovering over it, it gives you an explanation of which of these categories means. So if anybody wants to look at the dashboard and find, what does that mean? What does that mean? It's all there. And then you have the total population by ODS status. So we can tell that within care homes, there's a lot of flux. Care homes either close because of closures. You may have care homes that are taken over by different providers, and because of that, their ODS codes are renewed, and they have new ODS codes. And that means that if we've got residents associated with deactivated ODS code, they are still linked to that ODS code until it's corrected. So back at the start of the season, we had about 10,000 residents who are linked deactivated ODS codes. We've got that down to 218, and that is solely the result of working with developers to work out which ODS code still in the system is deactivated, and then developers have basically got an updated CQC list in the pipeline and made sure that the most recent ODS code for a care home is linked to the residents. We also have five residents who are linked to a care home which has actually been confirmed as closed. As we scroll down, we can see when I said earlier about having care home residents, only care home residents of Odorada care homes are vaccinated for COVID. So we can tell that the population for that is 356,000. And if we want to look at the top, the overall population is 407,000, and that is the flu denominator. And we can tell that 50,000 people are associated to care homes that are classed as non-older adults. And if you want to look at the data even in more detail, we can then break it down to say how many care home residents are in a nursing home, how many care homes are in a residential home, and how many residents are in a residential or nursing home. And the benefit of that is that if we want to look at a nursing home, you'll probably find that the majority of residents in a nursing home are those would be mostly vaccinated by a care home visit, whereas residents linked to a residential home will mostly be vaccinated by going to an external source. Now, I also like to have a look at estate movements. So we have a lot of movement. As I said before, we have a lot of this movement in the care homes estates. We have care homes closing all the time, new care homes opening. There's a lot of movement. Because of that, that's why we have to make sure the CQC data is as correct as possible and up to date as possible in the system. So one of the things we look at is site openings. So we've got a couple of metrics that say since the 1st of August, 302 care homes have closed. Since the 1st of October, which is when the campaign started, 182 care homes have closed. So this gives us evidence to go back to meetings of colleagues when they say we need to use just 1 month's worth of data for CQC reports. We say, well, we don't agree with that because there's a lot of movement, and this is the evidence to show that we should still be using the most accurate CQC data, because otherwise, if we keep the old CQC data in the system, we're going to have people linked to old data, and it's not going to mean anything. And then we have estate closures. So as you can see, it's still quite high numbers. Since the 1st of August, we've had 355 closures. And from the 1st October, we've had 212 closures. And as you can see, it's all broken down by individual regions. And then the thing we have as well is we have information. So we have a breakdown of the most current, the most frequently asked questions about the data, and it's all broken down in here. And then we have data definitions, which basically gives a breakdown of all the different metrics and what they are, which is all down here. We then have a option. So I'm just going to show you a few other things. We have an option called self-serve. So I'm going to open now. And this gives regions. So we have different regions in ICB that have access to this care home dashboard. So they're all asking for separate information. So what we have is the option to select different filters. So if they want to look at all care homes, that regardless of being closed, they can select that. They want to select all care homes that are JCVI eligible. If they want to include all care homes that have been excluded, we have a list of exclusions that regions ask us to exclude because they've got extra intelligence about the care home that we don't know about in the data yet. So they say, well, they'll say to us, we know this care home has closed. Please, can you remove it from the records so it doesn't come, so we don't chase them for data, and then we can just do that as well. So we have this data broken down by region, and basically it's just a list of occupied homes, homes visited, the percentage of homes visited, sites of activity, percentage of sites of activity, and so on. So this is the number game. And then if you scroll down, you can then download it as it's then done at ICB level. So we have the initials for the region combined with the ICB for that region. And then if even more granular level, you've got all the care home data. So you can go down to the care home level. And if you want to download that data, you click on this button here. And then you can download it as an extract. And then the regions can open up that spreadsheet, disseminate the data, and they can say if they want to talk to a particular care home, they can copy that care home's information into a small spreadsheet, send it to the care home, and ask them questions about that data. So this is used by care homes. Now, one of the best things about this is that this dashboard has been used this particular season by 65 unique users. So by having this FTP data linked to Tableau and being used by different regions, etc., that's 65 people we are removing from having to log into FTP and using expensive contours reports to access this information. So everything is pretty much there for them to use. We then have a site search option, which allows the user to type in the name of an ODS code for a care home. It will then bring up all the details for the care home. It will show you where the care home is located on the map. So if a care home was to have low uptake and have a high number of residents who've not been vaccinated just yet, the region can then suggest to the care home, well, there's this many GP surgeries in the area. Could you not send your residents there to get their vaccination? And what we have here is a number of different metrics. So we can say we've got 88 beds at this care home. It's got an eligible population of 119. So to me, that is one of the biggest data discrepancy issues we have, is because there's such a delay in getting residents' data updated on GP records. You sometimes have more people linked to the care home than they have beds. So we've got 119 people in a care home with 88 beds. And then we have deceased, displaced, and moved away 0. So there's no issues there. And then the next thing we have is missing VVE. So we know that 6 people have been vaccinated in that care home, but not showing as a resident on their GP record. So that's another data discrepancy that we can go back to the care home with. Now, if we want to look, we can look at this, so we can have a history of all the care homes that have been at our site. So for Barchester Health Hilton Care Home, we have 2 sites on that care home. So sometimes you can have what's called a primary and secondary site on the same thing. So first of all, so we're looking at Barchester Hilton Hill Care Home here. This is the one we're looking at, and it's got 119 people and 88 beds. But in the same care home, on the same address, there's a care home with 55 beds and no residents. So there is a discrepancy there where, in most likely, the residents of this care home, Barchester Oakland's care home, have been misallocated to the care home above. Sometimes you can have 2 different care homes on the same site managed by the same provider, which is true in this case, Barchester Healthcare Homes Limited. So we can tell for this site that there are two care homes on the same site, both managed by the same provider, but all the residents have been allocated to the incorrect care home, and they should be, so most likely a number of those 119 should be allocated to Barchester Oakland's care home. And if you scroll down further, you then have a list of all the care home visits in the area. If I scroll up again, we then have like a flu overview. So we want to look at flu and see how they perform in difference to other areas. So we want to look at, for example, East of England. They've got uptake this season of 73.47%. If you look at 2023, uptake was 36.37%. So there's actual difference there, 37.10. You then look at difference to flu. At this stage of the campaign, we were 69.77% uptake. So now 3.70%. So we're actually 3.70% ahead of where we were then, which is pretty good going. So it's a good indicator to see how we're performing in reference to other campaigns. The issue we have is that we can't go back to 2023 and get an accurate list of all the people who were care home residents back then, because our data is just not available. It's all real-time information. All we can do is make an exception. If they're a care home resident now, they may have been a care home resident back then. So everything is fully detailed. So you have, on each page, you have a timestamp to say when the dashboard was last updated. So this dashboard was last updated this morning at 9:24 a.m. And it also tells you what day of the campaign we're on, the last time somebody had a COVID vaccination administered, and the last time somebody had a flu vaccine administered. So that's pretty much the care home dashboard overall. We do have a few more bits on here. So as I say this before, we have like
Miles, I'm going to jump in there because I'm afraid I have to interrupt. We've overrun the time available to us, but it's because you've got so much to say and show us. It's been absolutely fantastic. Really appreciate it. And I want to give everybody a bit of an opportunity, not just for yourself, Miles, but anybody to Hamza and Anthony. If anybody's around, if they would like to fire us some questions, we can jump in with any questions right now before we close shop.
While you're thinking of questions, I will do our prize wheel real quick. So regular visitors will know we do a prize wheel of 3 prizes. So if you're still online, please drop me a DM. The DM is just next to the chat function to let me know your address, and I'll send you some swag out. So our first winner is Kate. So Kate, if you give me your address, congratulations. Our second winner is Chipo. So if you could send me that would be great. Thank you. And our third winner will be Andrew. So Andrew, if you could send me your address, and we will get some swag sent out to you.
That's absolutely brilliant. Thank you very much. Really appreciate the presentations from Anthony, Miles, and Hamza. If you do have any follow-on questions after this, then please do. You will be asked for feedback with an email. So you can write back to that, and we can pass any questions on to those people. And as Roland just said, Miles is back again next month, so that you can wrap up with a bit of a summary on where you were heading with that as well. But thank you very much, Anthony, Hamza, and Miles. Really appreciate excellent presentation.
Great. Thanks, guys.
Thanks, everybody.
Yes, bye.